Neurologic Neurologic Emergencies, that's chapter 18. And just like previous emergencies, respiratory, cardiovascular emergencies, and I believe we covered cardiovascular emergencies and allergy and anaphylaxis. These emergencies are common. So neurologic emergencies, very common. And the chapter will focus on stroke. It will focus on headaches, seizures, and altered mental status. National EMS Education Standard Competencies. Medicine applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely ill patient. Neurology, we will look at neurology, so that will cover anatomy, presentations, and management of decreased level of responsiveness, seizures, stroke. We will also be looking at the anatomy and physiology and pathophysiology with assessment and management for stroke or TIA, transient ischemic attack, seizures, status epilepticus, headache. Introduction. And stroke is the 5th leading cause of death and the leading cause of adult disability in the United States. The statistics might closely mirror what is occurring in the US. So the statistics in Jamaica might be close. It's common in geriatric patients. Contributing factors for stroke include family history and race, and there are no good treatments available if the patient can get to the hospital within a specific time frame. So time is important to the heart muscle. Time is important to the brain. Introduction still. Seizures and altered mental status may also occur. Seizures may occur as a result of a recent or prior head injury. Can be because of a brain tumor, which is abnormal growth of cells. Can be linked to metabolic problems, can be fever, febrile in nature, or it can be a genetic disposition. Possible causes of altered mental status. Now, altered mental status simply means that the patient is behaving in a manner that we would not deem normal. Well, let me not say we, but is not accepted as normal. So when you have a patient with altered mental status, it's very important to find out what is the normal presentation for this person once it's possible. So possible causes of altered mental status include intoxication, can be due to head injury, can be due to low oxygenation, hypoxia, can be a stroke, can be a metabolic disturbance. Because there are a lot of things that can cause altered mental status for a patient, the treatment will vary based on the cause. Now, let's review the anatomy and physiology. And it's a review. So if you're having trouble with the review, just go back to your anatomy and physiology lectures. It's all there on the platform. So the brain is the body's computer. It controls breathing, speech, and all body functions. There are 3 major parts of the brain: brainstem, cerebellum, and cerebrum. These are the parts that you need to be familiar with as an EMT. The cerebrum is the largest part of the brain, and it deals with all our conscious thoughts, things that we need to think about. All the conscious functions within the body that we have to think about is going to be the cerebrum. The cerebellum is responsible for balance and coordinated movement. That's the function of the cerebellum, often referred to as the midbrain. And the brainstem, which is the smallest portion of the brain and the most well protected, is responsible for life-sustaining functions. So the brainstem controls the most basic functions: breathing, blood pressure, swallowing, pupil constriction. Life-sustaining functions are also controlled by the brainstem. The cerebellum, the B and L in cerebellum, you will use that to remember balance and coordinated movement. So balance and coordination is the cerebellum. Now, the cerebrum is divided into the right and left hemisphere. The left side, persons who are left side dominant, so most persons use one side of the brain more than the other. Persons who are left side dominant are academically gifted, so they excel in academics. Persons who are right side dominant, they are more hands-on, they are more practical oriented individuals, so they excel when they are able to do things physically. Now, the left side of the left hemisphere, or the left side of the brain, is responsible for how we interpret and how we deliver speech. So interpretation of speech, understanding of speech is left side. The right side is, with the right side, it's how the speech comes out. So the right side of the brain controls the way the speech comes out. The left side is more understanding. So again, the cerebrum is divided into the right and left hemisphere. The left brain controls the right side of the body. The right brain controls movement on the left side of the body. Let me repeat that. So the left brain or left hemisphere controls movement on the right side of the body. The right hemisphere controls movement on the left side of the body. The left hemisphere has to do with how we interpret, how we understand speech. The right side is how the speech comes out. So the cerebrum is divided into the right and left hemisphere. Each controls activities on the opposite side of the body. The front of the cerebrum controls emotion and thought. The middle controls sensation and movement, and the back processes sight. In most people, speech is controlled on the left side of the brain near the middle of the cerebrum. Messages sent to and from the brain travel through nerves. 12 cranial nerves run directly from the brain to parts of the head. The rest of the nerves join in the spinal cord and exit the brain through a large opening in the base of the skull called the foramen magnum. At each vertebra in the neck and back, two nerves branch out. These are the spinal nerves. These carry signals to and from the body. There is 12 pairs of cranial nerves and there is 31 pairs of spinal nerves. You don't need to know these nerves, you don't need to know their function. But if you decide to move past EMT level, the higher you go in your studies, the more you're expected to know. So at an advanced or higher, it would definitely need to know these nerves that you can assess if they are functioning. So the spinal cord is the continuation of the brainstem. It exits the skull at the foramen magnum and extends down to the level of the second lumbar vertebra. So that's a review of the anatomy and physiology of the central nervous system. Now, remember that your brain, the brain and spinal cord makes up the central nervous system, and the cranial nerves and spinal nerves make up the peripheral nervous system. Now let's look at the pathophysiology. Many different disorders may cause brain dysfunction. They may affect the patient's level of consciousness, speech, and voluntary muscle control. The brain is sensitive to changes in oxygen, glucose, and temperature. So the brain cell cannot go without adequate oxygenation for more than 4 to 6 minutes. After that, brain damage or irreversible brain damage may occur. The brain needs a constant supply of glucose. So the brain is the only place in the body that the cells can absorb glucose without insulin. The brain doesn't need insulin to absorb glucose. That's how important glucose is to the brain. And the brain cannot function under extreme temperatures. Now, let's look at the first issue, headaches. One of the most common complaints can be a symptom of another condition or a neurologic condition on its own. Only a small percentage of headaches are caused by a serious medical condition. And the headaches that we will be looking at, there are other headaches outside of this, but these are the headaches that you need to be familiar with as an EMT. Tension headaches, migraines, and sinus headaches. And we will look at them individually. So a tension headache is caused by muscle contractions in the head and neck area. It is linked to stress. The pain is usually described as a squeezing, dull, or ache type pain, and usually it does not require medical attention. But one of the protocols we have at where I work part-time, I don't want to name the place, in the occupational health department, is if someone comes in with a headache and they require treatment, it's routine for us to ensure that a blood pressure check is done. Because worst case scenario, a severe headache could indicate that a blood vessel has ruptured. So that's your tension headaches. Migraine headaches. Now, the migraine headaches is due to changes in the size of the blood vessel at the base of the brain. The pain is usually a pounding or throbbing or pulsating pain. That's how they describe it. They might have triggers. It might, they might tell you that the pain is on one side of the head. Some might tell you that it starts around the eyes and then it's spreading out. It is often associated with nausea and vomiting, and it may be preceded by visual changes. Can last several hours or days. Then you have your sinus headaches caused by pressure that is the result of fluid accumulation in the sinuses. So these are spaces within the front portion of the skull. They are necessary to trap particulate matter, and it helps to regulate how our voices sound. Sometimes fluid accumulates in there if it becomes inflamed, and it can cause a headache. Usually, these patients will present with cold-like symptoms, which include nasal congestion, they can have cough, and they can have fever. Pre-hospital emergency care is not required. Now, serious conditions that include headache as a symptom. So these are some conditions that we would consider to be serious that are associated with headache. Hemorrhagic stroke. And hemorrhagic stroke will kill a person very fast. And the headache that they get with hemorrhagic stroke, the patient is going to tell you that they have never had a headache like this before. This is the worst headache they have ever experienced. Brain tumor can also be associated with headaches. It can also be associated with seizures. And meningitis, which is inflammation of the meningeal covering of the brain. That's a membrane. And the membrane has 3 layers. It has a outer tough layer. That's the layer that's directly below the skull. It is referred to as the dura mater. Then you have the arachnoid layer, which is where most of the tiny blood vessels are located, which is the middle layer. So the top layer is the dura mater, the middle layer is the arachnoid layer, and then you have the pia mater. The pia mater is the layer that directly attaches to the brain, so that's the soft layer. The covering can be inflamed, that's meningitis, and it can cause headache. A patient with meningitis will also have visual issues, and they're gonna have issues moving their neck back and forth. It's gonna hurt when they do that. Now, stroke. Also called a cerebrovascular accident. It is an interruption of blood flow to an area within the brain, and it can be as a result of a clot interrupting that blood flow, or it can be a blood vessel has ruptured. So you have 2 types of stroke. You have ischemic and you have hemorrhagic. The ischemic stroke is more common. The hemorrhagic stroke is less common, but more deadly. Now, wherever the interruption of blood flow occurs in the brain, whatever function that area of the brain is responsible for, it will be disrupted. So, ischemic stroke. Most common, accounting for 87% of strokes, results from a thrombosis and an embolus. And I explain the difference between a thrombosis, and a embolus. I believe it was the last session, but I'm going to go over it again. The thrombosis means that the clot forms in the area. So that's a clot that forms in the area. And it's going to be similar to the process of a clot forming in the coronary artery. So there is atherosclerosis that builds up in the cerebral artery, and over time, the cerebral artery diameter becomes narrow and the pressure starts to increase inside that blood vessel. Over time, it hardens. That's arteriosclerosis. And then the pressure can rip off a piece of the plaque and it plugs the artery. That's a thrombosis. An embolus is simply a clot that travels. That's what an embolus is. It's a clot that forms somewhere else in the body, like a deep vein clot. So let's say a patient has a thrombosis in their extremities, and that thrombosis dislodge. Once it's been dislodged and it starts to travel, it becomes an embolus. That's a clot that moves. Now, symptoms may range from nothing at all to complete paralysis. Atherosclerosis, that's the one with the fat, ATH, in the blood vessel is often the cause. So, atherosclerosis can damage the wall of a cerebral artery, producing narrowing and or a blood clot. When a vessel is narrowed or completely blocked, blood flow to part of the brain may be blocked, causing brain cells to die because of lack of adequate oxygenation. And just like the cardiac cells, brain cells do not regenerate once they die. So time is important. Now, hemorrhagic stroke accounts for 13% of strokes. It results from bleeding inside the brain. Cerebral hemorrhages are often fatal. People at high risk include those experiencing stress or exertion. People at highest risk are those who have very high blood pressure. So uncontrolled high blood pressure is a significant risk to hemorrhagic stroke, especially if the person has high blood pressure and is an alcoholic. Now, the hemorrhagic stroke pathophysiology or pathology, pathophysiology is the aneurysm. We spoke about this previously as well. So an aneurysm is simply a weak point in the wall of an artery, right? So the excessive pressure in the artery creates a weak point, and if the blood pressure is not controlled properly, eventually can cause that weak point to rupture, causing a hemorrhagic stroke. Now, a TIA, transient ischemic attack. The word transient means passing through. Transient ischemic. Ischemia is reduction in blood flow. So there is a temporary reduction in blood flow to the brain. That's basically what a transient ischemic attack is. So the patient will present with stroke-like symptoms, but these symptoms will not remain. After 24 hours, they subside. However, it is a warning. It is a warning sign that a serious stroke may be coming, right? So it's a warning sign. these patients still need to be evaluated. So you might get to the location, when you get to the location where the patient is, the symptoms may have subsided at that point. The patient needs to go to the hospital still to be properly evaluated because it's a warning. A stroke may be coming. Now, signs and symptoms of stroke, there can be a lot of signs and symptoms, but one of the common assessment tools that you should utilize is the BFAST approach, BEFAST, balance eye, and the eye here would be vision, facial droop, arm drift, speech, and time. So the BFAST method is a good way to assess if your patient is having a stroke. So with the B, is the patient having issues with their balance and coordination? Are they having issues when they walk? Do they look like they're drifting to one side? With the I, are they having vision issues? Is there issues with the vision, double vision, seeing to the side, seeing up? Do they have issues with the vision? The facial droop, does the right side of the face match the left side of the face? Is there symmetry? And if there is no symmetry, is this the norm for this patient? Arm drift, you ask them to extend the arms out with the palms up with the eyes closed. They will either be able to do it or the side that the stroke is affecting will not move or it will be weak. And speech, you give them a simple phrase to repeat. Can you say for me, today is a cloudy day? Do they understand what you're asking? And if they're communicating, how is the speech coming out? Is it slurred? So the BFAST method is a quick way of assessing if something is wrong. So signs and symptoms of a stroke: facial drooping, sudden weakness or numbness in the face, arm, leg, or on one side of the body. Decrease or absent movement and sensation on one side of the body. Lack of muscle coordination, we call that ataxia, or loss of balance. Sudden vision loss in one eye. Blurred or double vision, difficulty swallowing, decreased level of responsiveness, speech disorders. Aphasia, that's speech again. Is there a speech issue? Slurred speech, dysarthria, and aphasia would be left side, slurred speech would be right side. Sudden and severe headache, confusion, dizziness. Weakness, combativeness, restlessness, tongue deviation. They can also have issues naming objects, and they can have issues using simple objects. So the signs and symptoms vary. Now let's look specifically at the left hemisphere. Stroke in the left cerebral hemisphere may cause aphasia. This is inability to produce or understand speech. Speech problems can vary widely. May also cause paralysis of the right side of the body. For the right hemisphere, stroke may cause paralysis of the left side of the body. Usually the patient can understand language and they are able to speak, so they don't have any issues understanding. They don't have any issues speaking. However, if it's the right side, how they speak, the speech will be slurred. So they can have slurred speech if it's the right side. So in other words, you have a patient that you suspect is having a stroke. You tell the patient, repeat this phrase for me. Today is a cloudy day. And the patient says to you, I need a bottle of water. So you ask the patient to repeat the phrase, today is a cloudy day. The patient say, I need a bottle of water. That's left side, right? That's the left side of the brain. Something is wrong with the left side. They are not able to understand and interpret what you're asking them. That's left side. The right side now. Same patient, you tell the patient, repeat, today is a cloudy day. And the patient says, today is a cloudy day. So the patient understands what you're asking. They are able to speak, but the speech is slurred. That's right side. Patients may be oblivious to their problem. That's neglect. So they might neglect the affected side. Neglect and lack of pain cause many patients to delay seeking help. Bleeding in the brain. Now, patients may have high blood pressure. The high blood pressure may not be controlled, and it can be the cause of bleeding in the brain. So it may be caused by the bleeding as a compensatory response. Increasing blood pressure is an important sign. Significant drops in blood pressure may occur as the patient condition worsens. Now, what this slide is basically saying, if bleeding is occurring in the brain, it can be due to the patient blood pressure being significantly elevated, or it can be the patient blood pressure is elevated to compensate for a buildup of pressure inside of the skull. That would be a compensating mechanism. But increasing blood pressure is not going to be a good finding. Low blood pressure is going to be even worse. So the rise in the blood pressure could indicate that the pressure inside of the skull is increasing. We call that intracranial pressure. If the blood pressure starts to fall, then the entire brain is going to be affected. So neither is good. Now, there are some conditions that may mimic stroke. Hypoglycemia, which is a low blood sugar. Postictal state, which is the resetting phase of the brain after a person has a seizure. So there is a phase where the body tries to reset. And they usually present as if they're in this deep sleep in that state. Subdural or epidural bleeding. Remember, earlier we stated that the dura mater is the area just below the skull. So that's the portion of the membrane that is just below the skull. If bleeding starts to occur above the dura, that is referred to as epidural bleeding, and it's usually going to be an arterial bleeding. So it occurs very fast. If bleeding starts to occur underneath the dura, so it's underneath the dura but above the arachnoid layer, that's going to be referred to as subdural hematoma, or subdural bleeding. Now, with these bleedings occurring, the patient can present with signs and symptoms associated with stroke, but it's not a stroke, it's a blood vessel bleeding above or below the dura. And if the bleeding is occurring below, it's usually a vein, at this point. So the bleeding occurs more slowly, and the signs and symptoms develop gradually. If it's above, the bleeding occurs more rapidly, and the signs and symptoms will occur as such. Now let's look at seizures. Seizures. A neurologic episode caused by a surge of electrical activity in the brain can take the form of a convulsion and/or can be associated with a temporary alteration in consciousness. There are two basic groups of seizures. It can be generalized, which is used to be called a grand mal seizure, or it can be partial focal, which used to be called a petit mal seizure. Now, generalized seizures. This results from abnormal electrical discharge from large areas of the brain. It is typically characterized by unconsciousness and generalized twitching, severe twitching of all muscles lasting several minutes or longer. So you're going to see the muscle contraction and relaxation in these patients. Now, an absent seizure, which is also a generalized seizure, it is referred to as generalized because there's an alteration of consciousness. Now, with an absent seizure, there's no motor activity. The patient there's a lapse of consciousness temporarily, and then they regain consciousness. Now, because of that, it is difficult to pick up. It's going to be common in the pediatric population, but it's very difficult to pick up. So you might tell the child to pass a device, pass the book on the table and bring it to me. And the child just stop suddenly and have a blank stare. Some may collapse at that point, some may remain standing, and then the brain chips back in and they walk towards you, but they don't remember what they were doing. That's something to be checked out. So that's an absence seizure. Now, partial focal seizures. It can be focal onset, aware seizure, and all that means is whatever is happening, the patient's level of consciousness is still present, but they cannot control what is happening to their body. They are aware that something is happening, but they can't control it. So that is what focal onset aware seizure means. So there is no change in the patient's level of consciousness. They may have numbness, they may have weakness, they may have dizziness, they may have visual changes or unusual smells and tastes. They may have some twitching or brief paralysis. This type of seizure you can see in patients with brain tumors, frontal lobe brain tumors. Now, still on the focal seizure, they can have a focal onset with impaired awareness. So they can have a focal onset with impaired awareness seizure. It's still a focal seizure. However, the difference between this one and the aware seizure is the aware seizure patient still have a level of consciousness. They can understand that something is happening, but they can't control it. The patient that is having a focal onset impaired awareness seizure, their mental status has been altered. They have no idea what's happening. So they have a altered mental status. So it results from abnormal discharge from the temporal lobe of the brain. The patient will have lip smacking, eye blinking, isolated jerking, unpleasant smells, visual hallucination, uncontrollable fear, repetitive physical behavior. All of these things can occur. Oral and oral. Patients may experience an aura or aura prior to a seizure. Not all patients will have this experience. It can be a visual change. It can be an hallucination, which simply means that they're seeing or hearing things that is not there. People with a history of seizures recognize their auras. So persons who have a history will recognize the aura, and they know when they're going to have a seizure, so they start making adjustments before the seizure occurs. Miss Fiona, you need to fix that issue. It's distracting. You keep raising your hand. It's distracting. So try and avoid doing that, please. People with a history of seizure recognize their auras and usually take steps to minimize injury. Auras do not occur prior to every seizure, and not all patients with a seizure disorder will experience an aura. Right. Now, generalized seizure. Characterized by a sudden loss of consciousness, chaotic muscle movement and tone, and apnea. So they don't breathe properly during this time, which it's understandable, because if the impulses are firing erratically to the muscles, the diaphragm and intercostal muscles won't be able to function properly at that point. They may exhibit bilateral muscle movement characterized by a cycle of muscle rigidity. So the muscle get rigid, then it relax, rigid, relax. It typically lasts less than 5 minutes, followed by a post-ictal state. And the post-ictal state is where the brain resets. They go into a deep sleep state. You might hear some snoring. They start to breathe very fast. This is the phase where you can get a lot of stuff done. So if you need to clear their airway, clear it at that point. If you need to turn them on their side, you do it at that point. You can get a lot done during the post-ictal phase, because we don't want to try to restrict their movement. You cannot control a patient's movement physically that is having a seizure. If they can't control it, you won't be able to control it. You're only going to cause more harm to the patient. So the post-ictal phase is where we work. Absent seizure, formerly called petit mal, may last for seconds. Patient fully recovers with a brief lapse of memory. Now, status epilepticus. These are seizures that last more than 5 minutes and are likely to progress. Sorry, seizures that last more than 5 minutes are likely to progress to status epilepticus. Now, basically, status epilepticus means that the patient is having continuous seizures without regaining consciousness. So they have a seizure, post-ictal state, seizure, post-ictal state, seizure. They're not regaining any consciousness. When a patient has status epilepticus, this is a patient now where medication is going to be necessary to stop this seizure. That's outside the scope of an EMT though. Seizures that continue every few minutes without the person regaining consciousness or last longer than 30 minutes. That's status epilepticus. This patient will require ALS intervention. Now this table, 18-2, common causes of seizures. Can be epileptic, where they have a seizure disorder, congenital origin, can be structural issues, tumor, benign or cancerous, infection, brain abscess, scar tissue from injury, head trauma, stroke. It can be due to metabolic issues, hypoxia, abnormal blood chemical values, low blood sugar, poisoning, drug overdose, usually on stimulants, sudden withdrawal from alcohol or medication, or a sudden rise in body temperature, febrile. And febrile seizures are common in the pediatric population. Now, causes of seizures. Still, epileptic seizures usually can be controlled by medications. So these are some common medications that they would use to control epileptic seizures. Keppra, Dilantin or phenytoin, phenobarbital, Tegretol, Depakote, Topamax, Klonopin. The importance of recognizing seizures. Recognize when a seizure is occurring and whether this episode differs from the previous one. Recognize the postictal state and complications of seizures. Identify other problems associated with seizures. The postictal state. After a seizure, the muscle relaxes and breathing becomes labored. It may be characterized by hemiparesis, paralysis on one side of the body. Most commonly characterized by lethargy and confusion. If the patient does not improve, consider other possible underlying conditions. Now, syncope. Seizures are often mistaken for syncope. Syncope is the medical term for fainting. Fainting typically occurs while the patient is standing. Seizures may occur in any position. Even though fainting typically occurs when a patient stands, a patient can faint while sitting. And if they faint while sitting, then something else might be happening. Fainting is not associated with a post-ictal state. Now, let's look at altered mental status. Aside from stroke and seizures, the most common neurologic emergency is going to be altered mental status, which simply means that the patient is behaving in a manner that we would not deem normal. So the patient is not thinking clearly or is incapable of being aroused. In some cases, the patient will be unconscious. In others, the patient may be alert but confused. Now, causes of altered mental status. There are many. Hypoglycemia, hypoxemia, intoxication. So, low blood sugar, low oxygen levels in the blood. They might be intoxicated, drink too much, and it's never more than 2 beers. They may have delirium, and delirium is a severe mental disturbance it's a severe disturbance in mental abilities, which affects the patient ability to think, and it causes a reduction in their level of awareness to their environment. So that's what delirium is. It's a severe mental disability or mental change so why am I going all over the place? It's a severe change in the patient's mental ability that will lead to issues with their thinking, and it will cause a reduction in their level of awareness as it relates to their environment. The altered mental status can also be caused by drug overdose. I have various drugs, which you will discover that in your toxicology lecture. It can be due to unrecognized head injury. It can be because of a brain infection. It can be because of abnormalities with the body temperature, brain tumor, overdose, or poisoning. All right, so that's the pathophysiology of the problems. So we have looked at the review of the anatomy and physiology. We have looked at the pathophysiology, which is the problems that you will encounter in the field. Let's look at the patient assessment approach to these patients. So start with your scene size up, make an early determination whether the cause is medical or trauma once it's possible. Look for threats to safety, follow standard precautions, consider the need for spinal motion restriction, call for additional resources early. In your primary assessment, look for and treat life-threatening conditions, perform a rapid exam, establish priorities of care based on assessment of the patient's level of consciousness and XABCs, and the XABCs is more for trauma patients. The X represent exsanguinating bleeding or life-threatening bleeding. That's what the X represents. We tend to look for that more with trauma patients. After we have completed our ABCs, you should know what your patient's GCS is, whether or not you need to do a rapid scan, whether it's a load and go or a stay and play situation. Package your patient appropriately, put the patient in the back of your unit, patient can communicate, then you want to get your OPQRST sample, then your vitals. So history taking, investigate the chief complaint for unresponsive patients, gather any history from family or bystanders. If the patient is unresponsive and you cannot get info from family or bystanders or from the patient, then ensure that you include pupil reaction, pulse oximetry, and blood sugar reading in your vitals. If no one is around, quickly look for explanations for the AMS. Try to determine the events leading up to the incident, obtain a sample history. In your secondary assessment, vital signs. Significant intracranial bleeding leads to a great deal of pressure in the skull, compressing the brain. This will cause a slow pulse and erratic respirations and a high blood pressure and changes in pupil size. Very important slide. These signs and symptoms are referred to as Cushing's syndrome or Cushing's triad. If the patient has AMS, check the blood glucose level. For your stroke assessment, there are numerous stroke assessments that can be utilized. So it's going to be based really on your organization. But whichever stroke assessment you utilize, a Glasgow Coma scale must be a part of it. So stroke scales evaluate face, arms, and speech. You have the BFAST, mnemonic, spoke about that earlier. You have the Cincinnati Pre-Hospital Stroke Scale, that's a common one. You have the Los Angeles Pre-Hospital Stroke Screen. You have the 3-item Stroke Severity Scale. You have the Glasgow Coma Scale GCS score. So this is a BFAST stroke assessment, table 18-3. Spoke about this earlier, right? The BFAST. Time is very important to a stroke patient. Ideally, you want to get that patient to the hospital within a 3 to 4 hour window. Some material will say you can go a little outside of that, but ideally within a 3 to 4 hour window. And that means that should include the time that the abnormal findings are discovered, the time in which EMS is contacted, the time in which EMS reach the location and perform assessment and management, package, and transport to the hospital. Ideally, we want that to occur within a 3-hour window, or as I stated before, some literatures will say up to 6. Now, the issues in Jamaica is that persons are realizing that something is not right. So they come and find grandma, or they come and find their mother, and they are not behaving as though they usually behave. And they say, okay, give her some minty, or watch and see. Just watch her over the next couple of hours. Make we see what happens tomorrow. That might be too late, right? So you sit there watching, and then tomorrow it starts to get worse to the point that there is complete loss of function on one side. Can be that the airway is compromised as well. At that point, the treatment that could have been provided might be contraindicated. So the earlier the patient can get to treatment, the better. The Cincinnati Pre-Hospital Stroke Scale, you can look at that, table 18-4. It's another commonly used one, but it focuses only on 3 areas: facial droop, arm drift, and speech. You have the Los Angeles Pre-Hospital Stroke Screen, a little more detailed. You have the Item Stroke Severity Scale, or LAG. Level of consciousness, arm drift, gaze. Now, regardless of the stroke scale that is utilized, GCS must be involved. You must do the patient's GCS. You do a GCS for everybody, but it's extremely important to these patients. And the GCS looks at eye opening. So eye opening, verbal response, motor response. The most they can get for eye opening is 4. Most for verbal is 5. The most for motor is 6. So a normal GCS reading would be 15. So 13 to 15 may indicate mild dysfunction, although 15 is a score a person without neurologic disability would receive. 9 to 12 may indicate moderate dysfunction. A score of 8 or less means severe function is present, and you need to be prepared to manage the patient's airway aggressively. Now, after the secondary assessment, reassessment. Focus on reassessing the ABCs, vital signs, and interventions. Compare baseline findings with updated information. Watch carefully for changes in pulse, blood pressure, respiration, and GCS scores, notify the receiving facility of the patient's chief complaint and assessment findings. Now, emergency medical care. The ED physicians determine if there is bleeding in the brain for patients with suspected stroke with a CT scan of the head. If no bleeding is present, then the patient may be a candidate for clot dissolving medication. Thrombolytic therapy. Notify the hospital regarding the last time the patient was known to be without their current signs and symptoms of stroke. So the last time that the patient was seen normal is very important. Patients who have had a seizure require definitive evaluation and treatment. Supplemental oxygen is strongly advised for patients who are having a seizure. Protect them from harm, maintain a clear airway by suctioning, provide oxygen as quickly as possible. If head or neck trauma is suspected, provide spinal motion restriction or spinal immobilization. We're moving away from that term, so get accustomed to spinal motion restriction. For patients who continue to have a seizure, as in status epilepticus, suction the airway, provide positive pressure ventilation, transport quickly to the hospital, rendezvous with ALS if possible. Remember, we are going to work in the post-ictal state. You can't bug a patient when they're having a seizure. For your patients with headache, you should be concerned if the patient complains of a sudden onset, severe headache. That should be a red flag. A sudden headache with fever, seizures, and altered mental status, that's a red flag. Headache following trauma, red flag. For migraine, always assess the patient for other signs and symptoms that might indicate more serious condition. Apply high flow oxygen if tolerated. Provide a dark and quiet environment. Do not use lights and siren during transport. So avoid lights and siren. Can trigger seizures in these patients. Emergency medical care for stroke support. Look for signs of bleeding, ABCs. So the X again means you're looking for bleeding. Provide rapid transport to a stroke center. Maintain SpO2 level of at least 94%. If they don't need oxygen, don't give it. Oxygen therapy, not recommended unless the patient is in respiratory distress or is hypoxic. So just like your MI patient, if they don't need oxygen, we don't give it. For the stroke patient, if the oxygen is not necessary, don't give it. It can cause more harm than good. If possible, transport to a designated stroke center. For seizure, the patient may be in a post-ictal state upon your arrival. The patient may still be having a seizure. Continue to assess and treat XABCs. Protect the patient from harm. I don't mean you're going to physically hold the patient down. Clear their environment. If the patient refuses transport after a seizure, which can happen, contact medical control. Follow local protocols. For altered mental status, determine the cause, provide spinal motion restriction, provide airway and ventilation support, transport to the appropriate facility. And that would bring us to the end of this chapter.